Hi, Dr. Gullberg here, continuing our infectious disease lecture series. Today we're talking about drugs that we can use for fungi. Basically, there's about 5 different categories for antifungals. Most commonly used are the imidazoles. These drugs work on fungal cytoplasm. Generally, you have to watch these drugs because of drug interactions. They bind the liver CYP450 system. Back in the day, ketoconazole was commonly used. Now, probably fluconazole is our most active agent against the Candida species, other than Candida krusei. We can use fluconazole IV at 6 milligrams per kilogram per day for serious infections. Orally, it's used variably. But we're starting to see resistance with Torulopsis glabrata, which used to be called Candida glabrata, up to about 20% of the time. Now we have some latter generation imidazole agents like itraconazole, which is otherwise known as Sporanox, used for histoplasmosis, blastomycosis, sporotrichosis, and some Aspergillus strains, as well as used for onychomycosis. Voriconazole is out now also. It's got a 96% bioavailability. We use that now for Torulopsis glabrata, some of the more resistant fungi. Aspergillus can be used for Aspergillus, 4 milligrams per kilogram, Q12 hours. IV, then we can use orally because of its bioavailability. Posaconazole is now out also being used, especially in our neutropenic fever patients. Second class of drugs is the echinocandins, which work on cell wall synthesis. Cytal agents just like amphotericin B, but downfall is they're IV only. They are good for azole-resistant Candida and Aspergillus. We've got caspofungin, micafungin, anadulafungin. They've got pretty poor urinary concentration, but they're good drugs for us to use in the hospital setting for more resistant Candida especially. Next class is the polyenes, which are basically nystatin or amphotericin B. It's a cell membrane inhibitor. We use amphotericin B, otherwise known as amphotericin, at 0.5 milligrams per kilogram per day. Toxicities are rigors, phlebitis, bone marrow suppression, renal and hepatic impairment, electrolyte imbalance. Fortunately, now we've got lipophilic amphotericin B, which decreases this toxicity, but it's very toxic and expensive. Excuse me, not as toxic as it is expensive. The last group are the allylamines, terbinafine, which blocks membrane synthesis, used for skin and nail disease, otherwise known as Lamisil. And then just to mention 5-FC, which we use, it inhibits DNA. It can be used for fungal UTIs, but causes bone marrow suppression, and then also can be used as a synergistic agent in like cryptococcal meningitis. So these are kind of a general picture of the antifungal agents that we use clinically. Hopefully this will help. Thanks, Dr. Gullberg signing off.